Unshelling Medicine Podcast. Healthcare in the language we understand.
Hello, good day everybody. This is Idonsit Obeya from Altruistic Scribe. Today with me I have Dr. Mitchell Yass. Dr. Mitchell Yass is the creator of the Yass Method, which has been utilized to resolve the pain of thousands, including those who had surgery to resolve pain in the past. So, Dr. Yass, please tell us about your incredible journey and experience in medicine.
Sure. So my journey actually starts as a child. I was taught analytical thinking, how to theorize, and therefore I was not the type of person who was just going to take information in. I was going to analyze information, and if it wasn't logical and made sense, I wasn't going to accept it. So I entered physical therapy school at 30 years old. It was a second career, and it became quite evident that what was being taught was baseless. It had no sense of logic to it. And so I said I would basically just try to get the degree, and then I try to figure out how I was going to treat people. In my last semester, that's where you're going to do your affiliations. I am now in front of people, and I am now going to treat them, and I'm compelled to ask them, can you please point to where your pain is? And when they pointed to where their pain was, it was not where it should be, based on the identified structural abnormality from an MRI, like a herniated disc or arthritis. Well, if the pain is not where it should be, based on that structural abnormality, by definition, that cannot be the cause of that symptom.
Right.
So the only thing I knew was true was the symptom was real in real time. And if I could interpret the symptoms, then I could establish what tissue was in distress. And in doing this process, I found in more than 98% of cases, the cause of pain was muscular, even when structural abnormalities were identified.
Right.
4 years prior to this, me entering physical therapy school, I had taught myself the physics of weightlifting and developed a method that I could isolate muscles and progress resistance and strengthen them quickly. And that became the basis of my treatment model. So immediately after graduating and treating people, I found I was getting people better in a session or two, and that became the basis of my method.
Wow, that's incredible. So I know that we're talking about acute pain here. Does this also apply to chronic pain?
Sure, yeah. So let's just define the two.
Right.
As far as I am concerned, in more than 98% of cases, the cause of acute pain is the fact that you live in a gravitational environment. There is a force requirement for all activities, and there are certain muscles required to perform each activity. If the force output, how much force the muscle creates, is not equivalent or greater than the force requirement, it will strain and elicit pain.
Right.
That is the reason for 98 to 99% of people's acute pain. The reason for chronic pain, which is acute pain lasting more than 3 to 6 months, is simply misdiagnosis.
Right.
The MRI improperly identifies a structural abnormality, thereby allowing the muscular cause to remain. And since it remains and has never been strengthened and the force requirement of activity still remains, the muscle continues to elicit the symptom. That is why chronic pain exists.
Okay, that's great. So for anybody who was not sure the difference between chronic and acute pain, you heard the definition. Basically, chronic pain is acute pain not treated properly or not managed properly.
And lasting greater than 3 to 6 months is the technical term.
The technical term, lasting longer, that time frame.
Yes.
So, Dr. Yass, when it comes to your method, where do you think the level of care for applying your method would be appropriate? Would you say at admission at a hospital? Because you did mention surgical patient. Right now in the hospital, acute care setting, I should say, which is a hospital setting, the implementation of getting our patients up within the 24 hours time frame of having, say, joint replacement, right? So where do you think that your method would be most effective to start? Would it be at discharge when physical therapy, occupational therapy is heavily involved, or right after that surgery when we're getting this person up to walk?
Let me explain the fact that I am telling you that in more than 90 to 95% of cases of hip replacement, joint replacement, any replacement, that surgery was never required.
Wow.
The failure rate for back surgery is 70 to 80%. They created the diagnosis, failed back surgery syndrome. There has been an opioid epidemic, which is due to the idea that you're trying to mask symptoms versus identify the cause and resolve it. How could anyone in any sense of logic say that the existing system is a viable system? It is clearly not. The answer is, upon experiencing a symptom, an evaluation should take place and determine, is that symptom from a muscular cause or a structural cause? In 98 to 99% of cases, it's muscular. The person can then be shown the appropriate exercises. The symptoms are resolved in 4 to 6 weeks. Fully functional. They sustain the exercise routine. It never comes back again.
Wow, that's incredibly eye-opening.
If you'd like, we can pick and choose. Let's give some examples.
Right.
Let's talk to straight, obvious things. So let's talk about hip replacement. Hip replacement, very common. What is the common symptom associated with hip replacement? Groin pain. The average person is told, oh, that groin pain is being referred from the hip joint. That is the standard. I took an x-ray. Oh, you see, arthritis, bone on bone, more lie. Since that's found at the time of the groin pain, I will assert it's the cause. Let's give you a hip replacement. So let's go through the rationale, whether that's viable or not. Number one, if a person's told they're bone on bone, that is to say there is no joint space. That's what bone on bone means. Well, what is the purpose of the joint space? It is to allow one bone to glide on the other so that range of motion can occur. Right. So if you were in fact bone on bone, I would expect you to have a major loss of range of motion, not pain, a major loss of range of motion. And at that end range, it should feel like a bone hitting another bone, stopping further range of motion. I've been doing this 30 years. I've treated 18,000 people. In 2 times, I found someone was bone on bone. And the other multiple thousands of times where that person was scheduled for joint plug replacement, they had full range of motion. So that does not sound like they are bone on bone, and therefore the surgery was never going to work. Secondly, if bone on bone was magically the cause of pain, that would mean pain would be in the joint, and I can confirm that if I laid the person on the side, took my hand, put it on the hip joint, compressed the thigh bone into the joint. That should cause lots of pain. Well, I've done that thousands of times, and it never initiated pain.
Right.
But I have pressed in their groin area, and they get writhing pain. That indicates that the pain is point tender, meaning it is coming from the tissue in distress where I pressed, which happens to be the sartorius muscle. So by confirming that the pain is not referred, as they were told, but point tender, I just reaffirmed there's no chance that the pain was from the hip joint. Therefore, hip replacement was never going to work.
Right.
You would also see that there's an associated change in posture. The height of the pelvis has been changed.
Yeah.
Well, height of pelvis is based on the gluteus medius muscle.
Right.
And if the gluteus medius muscle is strained, altering the height of the pelvis would alter the length of the sartorius muscle.
Right.
So actually, the cause of the pain of the sartorius is a strained gluteus medius muscle.
All muscle involvement. I don't hear bone or joint involvement. It all sounds like muscle compensation. And,
Well, I don't understand. If that's how it presents, just because you'd like to do surgery or you get paid for surgery doesn't mean you should do surgery.
Right. So for average listeners who are not medical providers, right? So when we talk of range of motion, because you did mention that if it was actual bone on bone, there would be no range of motion. And, we know in joints we have, synovial fluid. We're supposed to have cartilage and all the nice stuff that should be there. So if somebody who is not of a medical background should ask you, what level of range of motion are you looking to see to determine with those 2 cases you said in all of your years of experience? You've only seen 2 cases with bone and bone. What is the degree of range of motion that would concern you? And what is range of motion? Let's just explain it to the average listener.
So let's talk logic. You have pain in the right groin.
Right.
I would assume that your left hip joint is fine because you don't have any pain there. So I would check the range of motion of the left joint and whatever that presents as, because I know that's range of motion that doesn't create pain, I would check and see how the right side relates to it. And I'm not talking about impedance from pain. I'm talking about I'm going to try to push that thing and I want to see if it has an equivalent range of motion. That's how you determine it. If it's some single-sided, whatever the unaffected side is, that's the baseline. We have to assume that's the baseline because there's no symptom. So that's how I tell everybody. All I'm going to do, and you could do it yourself. If you think someone told you need a hip replacement, sit in a chair. If it's your right side, take your knee, pull it to your chest on the left, and then now pull the other one to the left on the right. And if they're roughly the same, you're not bone on bone, and surely the joint is not a factor in eliciting your pain.
Right.
You're being coerced into what is known as correlative theory. This is the way it works. You have pain. You then get an X-ray or MRI that finds a structural abnormality. And since the structural abnormality is identified at the cause of pain, it is asserted to be the cause of the pain. That is called correlative theory. It's like me saying, if I open my front door when the sun rises, I could say opening my front door caused the sun to rise. Look at the power I have. No one would believe my opening the front door caused the sun to rise, but I could show it to you. Well, that's the same thing here.
Right. Understood. So I really like this conversation because it keeps people out of the hospital. It keeps people from having unnecessary procedure performed on them when they can be managed without invasive procedures. So where would you target intervening before it gets to that point of going into a hospital? Are you focused in, collaborating with primary care providers in the community, orthopedic providers in the community health workers, or just the general public, educating the general public about the need to know information so they're not coerced, like you said, into unnecessary procedures?
All right, so let me ask you this question.
Right.
So this person has horrible lower back pain, and they determined that there's 4 herniated discs in the lumbar region, and they decide to do a $350,000 multi-level fusion. And that person comes out with more pain than before. They can't get out of bed. Does that surgeon get paid?
Oh, absolutely.
Oh, that's weird. That's weird. So he got paid without outcome. So let me ask you this. What's the incentive to have a positive outcome?
There's none.
Oh, that sounds right. There is no reason for positive outcome. And as a result of that, why would anyone think the system's going to change?
We don't think the system is going to change. Where we can make an impact not on the systemic level, because healthcare is very buttoned up. Is very much, who old boys, whatever you want to call it. And things are the way they are because it is profitable. Healthcare is a business, right?
Correct.
However, this business was put in place to help people. We have seen over the course of many years with studies, reports, and things that it's not really what it is, right? That's why we
That is correct.
Disparities in healthcare. We have inequities in healthcare. We have lack of education for the patient population in healthcare, which is why I do what I do, right? My business is solely focused on the consumers, because if I can empower you to advocate for yourself, because if I walk in there to talk to a doctor who's been a surgeon for 20 years, the ego trip is going to happen for somebody who is not willing to listen, right? But if I can empower my patient to ask the right questions, advocate for themselves, a lot of these procedures like you're talking about, right? I've seen it time and time again. So this is, you and I know is not new, right? So if we can empower the everyday people, if you can empower fellow healthcare providers to be knowledgeable, to push out education in the right way, I think that is where we make the impact. And, they can join eventually. But when they have enough patients questioning practices, right, then they'll take into account, okay, why is it that this is happening? Okay, let's bring the data, because we're in science, and take a look at it. Is there validity to these concerns?
Yeah. So just a quick brief hit on studies. 1994, the first study on people with no back pain showed 70% of the population have herniated or bulging discs. Postmortem studies of the 1950s showed 40% of the population had herniated discs. Where was the outcry of chronic pain in the 1950s? Studies on people without hip pain showed 75% have arthritis or labral tears. Over the age of 60, people who don't have back pain, 93% were found to have degenerative disc disease. So here's a thought. The mechanism by which the diagnosis of chronic pain is being derived is basically baseless. So here's the first question you say to anybody you know. Very simple first question. The pain that you have, is it increased with activity and diminished when you stop the activity? If that is true, which it is in 98% of the people I've ever treated over 30 years, they always associate their pain with I can't stand up, I can't bend, I can't go upstairs, I can't kneel, I can't reach because of pain. You just confirmed irrefutably your problem is muscular. Mm-hmm. Assuming it's muscular, who exactly in the magical world of the medical system is to address a muscular deficit? And please don't say physical therapy. I have a doctorate in physical therapy. It's nonsense. There's no weightlifting 101. Show me weightlifting 101 in the 7-year medical system of physical therapy, and I'll walk away. I'll never have a problem with it again.
Okay.
Is there a weightlifting 101?
No, I've not seen it. I haven't seen it. Yeah.
That's right. So what I do is self-taught. That's what makes this different than anything else on the planet.
Right. It sounds like it. It sounds like a lot of thought went into it. It sounds like a lot of dedication of your time and applying the knowledge you were taught and the sensibility that you had to make sense of everything, right?
That is right.
And that is incredible. It is incredible. When I meet professionals like you, it renews my hope that, there's certain people that still look out for the good of humanity. Because, yes, we love what we do. We love helping people, but I want to help people in a way that makes an impact, right? Not just, the status quo of, almost industrial in nature. This is what you do because this is your degree. This is what you do. This is your degree.
Here's a thought. How about caring about somebody? How about looking at that person that walks in your door, that man or woman who can't support their family because they can't go upstairs and their job happens to be 8 floors up? How about the woman? You want to talk about perverse? The lady that was 37 years old that had sciatica, who it was so bad she could not bend down and hug her 2 children. They had to get on a chair just so she could hug her children. This is the reality that I live in every day. Every one of those people is personal to me. Every one of them has a right to be without pain and to live the life they justly deserve. And there has to be a pathway for every person on this planet to be able to live that life. And as far as I'm concerned, I have been given that understanding, and that pathway is coming. It's just time now.
I love it. So, Dr. Yass, what you do on the other end of things, we're having a very realistic conversation here. So let's talk about coverage, insurance coverage, and how you get paid. Given that you have a proven success rate, is this something that the commercial insurance or even CMS is willing to pay you for the service that you provide to the patients that come to you?
So there is the magic words called standard of care. The medical system exists based on standard of care. Insurance companies pay by standard of care. Standard of care does not represent outcome. Nobody wants to vary standard of care because it's the standard of care. It's how we're going to do what we're going to do. We don't care if the person gets paid. As long as we're following that, we're fine. And as long as there's ways of manipulating the financial end of this, which is simply increase premiums, reduce deductibles, and reduce fees to practitioners, I don't have to think very hard. I could just keep this cycle going forever.
Right.
The person that comes to me has made a very clear and conscious decision. You pay me cash. I don't accept any insurance. I'm not part of any insurance. I don't want to be a part of insurance. I went bankrupt when I was a medical practitioner and was paid through insurance. I want no part of that. You will either make the decision. I am taking responsibility for myself. It's $200 for a session. The average person doesn't see me more than 3 or 4 times total during the process of becoming pain-free, fully functional, and learning the mechanism, the exercises to achieve that pain-free and fully functional. I have made this quite reasonable for the average person. No one thinks it's outrageous. In fact, people think I should be paying thousands of dollars, but that's disgraceful because that would mean only rich people could afford this, and I'm never going to do that. This is service to people who are in need. So people will have to at some point make a decision. You want to stay with your little insurance situation. You want to pay your $40, $50 copay, which I hate to tell you, after 6 to 8 months and 2 to 3 times a week, you're already in for $1,000 to $1,500. And you're no closer to getting a symptom resolved because you still haven't figured out your cause, versus coming and getting something that is clearly exacting. The average person with me has an 80 to 100% reduction in symptom and return of function by the end of the first session.
Wow.
There is no one on the planet. Anybody will tell you I'm insane to make that statement. I'll bring in 1,000 people in the store right now and they will tell you it's 100% true.
We believe you, Dr. Yass. We absolutely believe you. I know that is usually like the pain point, when you talk about services and, deviating from the status quo, that people often get anxious, and rightfully so, because a lot of people are on fixed income, right? So people often get anxious about, oh my goodness, how much is this going to cost me, right? So it's important that on this conversation, we establish that so that anybody who wants to reach out to you for consultation, whatever it is, can feel like, okay, this is something that I can afford. Just like you mentioned, the $40 copay adds up. And when you go to copay, you go to orthopedic specialist, then you go to physical therapy, then you go to your primary care for clearance, then you have to go to cardiology for clearance before surgery. And all of these things, it does add up to that $200 that you're talking about. So you and I know that there's a process to this, madness or procedure, whatever you want to call it. So it's up to an individual to make the decision whether it's worth it for them or not. So for people who may not be in your immediate geographical area, who may be interested in consulting with you, so how would they do that?
So I've been doing Zoom sessions since 2015. I've treated people in 10, 15 countries already. After this, I have a guy in Canada I'm going to do a Zoom session with. This diagnostic capacity, here's a couple of key points you want to understand about muscle. Muscle is responsible for posture and movement patterns. And so whether you're in the same room with me or not, if you have pain at this shoulder and that shoulder's higher, I can tell you right now that part of the reason you're having that problem is your lower trap. The muscle that is a shoulder blade depressor must be a factor in stabilizing your shoulder blade, which is why that's elevated. Then if I say raise your shoulder where this one doesn't come up at all as I'm doing it, but as this one does, that's what happens. It's, again, reinforcing that. So I don't have to be in the same room to do this type of analysis. In lower body, if the posture, your hips higher than the other, you're in an anterior tilt, you have a forward center of mass, the way you walk is, in fact, I can see all this whether you're in the room with me or not. So the only thing that's different is I can't do massage or stretching, and that does impede the ability to get you super fast. But the reality is, if muscular deficit is the cause, we will get you stronger and you can still be pain-free and fully functional within weeks. I never discuss months or years. Right. Never. It's weeks. So could I just bring up one point about, I just want to really hit this home for people to think about this. So they're having cardiovascular problems, they're having gastrointestinal problems, pulmonary problems. So here's a thought process. Here's what I want people to think. What is the primary system in the body that allows you to exist on planet Earth? Okay, you happen to unfortunately live on a planet where there is a massive gravitational force. So barring laying down flat on the ground, you don't go to the bathroom, you don't take a shower, you don't drink, you don't eat, you don't comb your hair, you don't do anything without muscle. Okay, so you end up having pain, muscle deteriorates and weakens because you're not utilizing them fully because you're not doing a full level of activity. What does that mean to the other systems? All those systems, your pulmonary system is designed to get oxygen to blood, to muscles so they can function in an aerobic style. Gastrointestinal system works to get glucose to your muscles so they have energy in anaerobic style. Cardiovascular system works to circulate that blood to all those cells. Immune system works to prevent it. So spleen and all that siphons poisons, okay? All those systems exist to sustain the musculoskeletal system. So when your musculoskeletal system deteriorates, you are affecting the functionality and the health of all your systems. You take my way of doing this, strengthen yourself back, become pain-free and fully functional, you have just heightened the functional level of every one of those systems, and you have just reduced the chance of having cardiovascular costs, pulmonary costs, gastrointestinal costs, any type of cost, because now your body is working optimally. That's what you want to understand about this financially.
So I'm so glad you brought that up, because this is what I tell my students, when we're in any nursing lecture, and I tell them, everything in your body is connected. It may sound stupid, but every single thing is connected.
Absolutely.
So the normal walking that you're doing every day, to you, is just that stuff you do. But the muscles in your legs are contracting, sending that blood where it's supposed to go. The valves are closing in the big vessels in the muscle, so it can pump it back to your heart and oxygenate and flow it back to your body, right? There is no vessel in the body that doesn't have a muscle, right? Mm-hmm. So even the blood vessels have thin muscles within them, right?
Sure, arterials.
Intestinal tracts have muscles, smooth muscles, peristalsis. What do you think that is? It's contracting and releasing so that things can move along. So when the muscles are not moving at their optimal rate, things are going to slow down, right? Things are just not going to function. So we cannot play around with muscles because we feel like, okay, they're there. No. They not only serve in function of movement, they also serve in function of supporting all your lymphatic systems as well.
Yes.
Yes. So I'm so glad you touched on that. The one thing that we see in hospitals when people go to surgery, going back to surgery again, right after surgery, we slap on a sequential compression device on your leg. Why is that? I think I'm stressing you out, Dr. Yass.
No, you're actually hitting a very, very important point, which I am so glad you're saying this, because I want people to understand. You just said it. Muscle is not just associated with muscle.
No.
So basically, the lymphatic system works by gravity pushing down. The only thing that pushes up is contractile force of muscle inward. That's what creates the upward force.
Absolutely.
And so because the person has surgery, let's say they even had pneumonia or something, that day 6 weeks later, when they try to get out of bed, they have massive swelling in their legs, and everybody's like, what happened? What happened? It's the fact that their muscles weakened for the 5 to 6 weeks they were immobilized. So stop putting a compression sock on them. Get them to goddamn walk. Watch how it suddenly goes away.
Right.
That's the answer. Organize the body. Stop adding stuff. Let the body learn to heal itself. That's how it's designed.
Absolutely. The body knows what to do. It can heal itself.
Absolutely.
Just get it back to its normal function. Let it do what it's supposed to do. Those SCD devices, the reason why they really slap them on, and also the Lovenoxes of the world, the blood thinners, is to prevent DVT. Why would DVT be a concern? Because the muscles are not contracting and sending those blood flowing the way it should. So all of these things are very important things that everybody needs to know. The general public needs to be educated so they can better advocate for themselves. A lot of hospitals, the one particular hospital that I currently take my students for clinical, they have this program that the dedicated techs that get the patients up right after surgery, and they've seen incredible outcome. So They tested it out on this medical floor, and they're expanding it to the rest of the hospital. So it is very important. I know you're hurting right after surgery, but please get up and move. It's going to save your life.
Well, one brief point I can make about that is, why can't you do some using resistance bands, do some exercises in the bed, which will enhance circulation, but also start activating individual muscles so that then that person can get up and walk without having symptom.
Right.
Well, what's the problem there? Why is that such a complicated idea? Oh my God, the 20-cent resistant band that's going to break the bank?
It's a lot of work, Dr. Yaz. You're asking to. So all these things, and also if you are a medical provider, I'm talking about the nurses, the physical therapists, specifically the nurses. Let's use that COSPAR acronym for assessment, right? So if you're assessing pain, okay, COSPAR, okay, we all know what that is for the nurses listening. I'll put that in the show note as well.
Tell me what that is. I've never even heard that.
Oh, no? Oh, my goodness. It's
What does
a
that mean?
good acronym for pain assessment.
Tell me.
So, yes, in pain assessment, the C, so COLDSPA. So C is the character. So the characteristics of the pain, right?
Okay.
So I come to assess you and I ask you on a scale of 0 to 10, can you rate your pain for me? And you're telling me, hey, is an 8. Okay. And then what is the characteristics of the pain? Is it shooting? Is it hit? The onset of the pain. When did it start? Right after your surgery, after physical therapy got you up. When did it start? The onset of it. All right.
Nice.
The location. You touched on it in the beginning, right? MRI shows there's deficit under, the right hip, but where the patient points to the pain is slightly off the right hip, right?
Right.
Where is the location of the pain? The duration of the pain. How long does it last when it comes on? Right? I need to know. Tell me how long it lasts. Then S is the severity of it. So you already told me the 8 of a 0 to 10, right? So I know you rated this pain at an 8. So it is a problem, right? So the pattern of the pain, is it intermittent? Is it constant? I need to know, right? Then the A is the associating factor. This is where we talk about aggravating with activity, aggravated at rest, or consistent or sustained through rest periods, and all of that stuff. So that is the acronym that nurses use to do pain assessment.
Okay, so here's my question to you. You did that assessment. What does it mean to you? That's my big question.
I did that assessment so that I can better intervene, because we don't only teach administer the prescribed therapy. We teach help relieve pain, repositioning, right? Help with motion, range of motion. So if you're telling me you feel some tightness or whatever is going on with your leg, okay, maybe I can get you to walk. Can you tolerate pain? Can you tolerate activity after I medicate you? That's the one thing that I always ask my students to make sure they determine what is the tolerable level of pain, because we all have it, right? Your tolerable level of pain may be a 5, right? And mine may be a 3. And the doctor prescribed us the same therapy, right? And mine can go down to a 3 and yours may not even, budge. Right? Then you have to have the breakthrough stuff. Until you get to a tolerable level of pain, you're going to be hesitant and quite fearful to participate in any activity. So I want to encourage you to get up with me so we can walk this thing off, get those muscles moving, get things back in place, get things back in balance, right? So I will do my responsibility of administering the pain medication only to do my own nursing intervention. That is why in nursing, we have nursing, doctors don't like it anymore, nursing diagnoses, but now we call them nursing assessments. So in making a nursing diagnosis based on the pain reported, we can then plan nursing intervention, actionable nursing intervention, and reassessment of those interventions to see if they were effective holistically to address the pain.
So my question to you is, pain is an indication of a tissue in distress.
Yeah.
That's what it is. At the end of your assessment, do you feel confident that you could identify the specific tissue associated with that symptom so that that tissue can be addressed appropriately, thereby ending its need to elicit the emergency distress signal of pain, and that would end the cycle? That's my question. With that, an acronym, does that get you there? That's my question.
That's where you come in. Remember, this is a collaboration. That's where you come in, because I'll be able to tell you, hey, Dr. Yass, this is what this patient report. I don't only give you a number, right? I can give you the characteristics. I can give you the onset, right? I can give you everything that you need to say, like, okay, yeah, I feel this is the muscle affected, right?
Okay.
That is the approach to interdisciplinary care model for patient. It doesn't always happen in the hospital only. Even in the community care setting, right? So if you're working with a nurse who's doing your intake, right? The nurse gets on the first phone call with this person. Hey, your pain is here. Your pain is here. When does it start? Does it get worse in the morning when you get up? Does it get worse at night when you go to bed? Does the weather changes affect you? How bad does it get? When you take whatever you take, does it relieve you at all? What do you do to affect this pain? So these are the kinds of things that nurses do. And I encourage my nursing students, when I teach, pain assessment is a big thing for me. Because again, whatever I report is what I'm feeling, right? You cannot tell me how bad my pain should be.
Correct.
It's very subjective, right?
Correct.
Well, in you identifying my subjective report of pain, you have to understand it. A number is not enough for you to understand it. A number is not enough for you to localize and give the doctor an idea of what to focus on, or physical therapy, what to focus on, right? So if I'm able to get the treatment to bring you to a tolerable level of pain, that I can do distraction, visualizing exercises, or I can take you out on a walk or have physical therapy, maybe increase something or do something for you, then I have done my part in helping get you to wellness, right? But if I only depend on you to tell me a number, what is that?
I like it. I think you're going in the right direction. Really good. So here's the general principle about how my system works here.
Right.
The person is having symptoms. They understand their symptoms to an exact level, extreme degree of accuracy.
Yes.
I know tissues. I know every symptom that every tissue has ever created. I've cataloged this for 30 years. We suck independently. We are spectacular together. So my job is to get every single thing, whether it's through verbiage,
Right.
motion,
Right.
looking at the way they do something with a hand, a shoulder, anything. And then from there, I can ascertain what tissue I believe is creating that.
Yeah.
And then I produce a treatment based on that decision as to what that tissue is. And if I'm correct, their symptoms go down. So it has forever been understood. If you walk in my door,
Right.
this is a team effort. Don't think you're going to sit there, because I'm not touching you for at least 20 minutes to a half hour until I've had a massive conversation and we've done some sort of testing, physical testing.
Right.
So I am in a complete agreement. You're going in a really good direction, trying to expound, to expand on the understanding of what that person's going through is your best chance of understanding what to
Yes,
do.
you have to. How are you going to treat me if you don't understand me?
Right.
How are you going to treat? Like,
Exactly.
what are you pinpointing? It's a number. I just gave you a number.
Right.
What does that mean?
Right.
Okay.
Means nothing.
Nothing. Nothing. I'm not able to tell you the characteristics of this pain. Is it shooting? Is it stabbing? You need to know that, right?
I like it.
So it's utilizing, it's not just saying, oh, how are you? You have a headache. Okay, great. Good for you. Here's a Tylenol. What kind of headache am I having? Is it a migraine? Is it frontal? Is it temporal? Right? All of that is important because it pinpoints what is happening. Am I dehydrated? Am I stressed? What is
Nice.
going on? Right. So you're doing great work, and I'm so happy we got on this call together. And this is not going to be our last call. We're going to continue this conversation because I absolutely love what you're doing. If we can avoid having invasive surgery, please let us as a community support everybody who's willing to heal holistically without having invasive procedures done. So this was such a
Just
good-
give people the chance to live their life, man. If they want to take the responsibility and do put the effort in that they need to have that life, that's great. If they don't, that's their choice too.
Right.
But at least let's make people aware that they're in a position to take much more responsibility than they thought, and that in most cases it's a muscular cause and they can help resolve it and achieve a high level of function. That's all I'm asking for.
Right. I think that's all everybody's asking for.
Yeah.
Everybody just wants to live a normal life, whatever normal is for anybody. I can't even imagine as a mother not being able to bend down and hug my
Oh.
You have to get on a chair. That is incredibly disheartening. But
Yes.
you know, Thank you for the work that you do, Dr. Yass. I cannot wait to, publish this episode. Please, for the show notes, I will get your information on how people can reach out to you for consultation and, treatment. And please, everybody that is listening to this, we want you to join the conversation. We want you to advocate for yourself. If you're a doctor, nurse, physical therapist, please advocate for your patients to have holistic intervention first. Worst comes to worst, then nothing happened, nothing improved. Yes, we can consider surgery. Surgery should be the last resort after we've gone through everything. So please advocate for your people. This was great, Dr. Yass. This was really good.
It was a pleasure. I enjoyed it. And I think you're doing great work. And I love to listen. I think in your way, you're helping people, man. And you're trying to enlighten medical practitioners who maybe they're out there. There's some people. Listen, there's some people caught in this system that don't want to be like that.
True.
And you're giving them a chance to have a voice and a possible direction. And that's a good thing. That's really a good thing.
Thank you. I appreciate it, Dr. Yass.
Yeah, absolutely.
Thank you, everybody. And yes, thank you for coming. And I look forward to having you again, Dr. Yass.
Oh, my pleasure.
Thank you.
Thanks for tuning in to Unshelling Medicine Podcast. If you want to stay up to date with the latest episodes, make sure to hit that subscribe button on your favorite podcast platform. If you enjoyed today's episode, please take a moment to leave us a review. Follow us on social media at Altruistic Scribe on Instagram, TikTok, Facebook, YouTube, and LinkedIn. We share additional tips, updates, and health-related content that you won't want to miss. Have any questions or topics you'd like us to cover in future episodes? Reach out to us at altruisticscribeco.com. We're always eager to hear from our listeners and tackle the health topics that matter most to you. Until next time, stay healthy and take care.